change to our agenda has been approved. And proceeding onward with our agenda under new business, we do have an update from our hospitals on the current status of our health system capacity from Dr. Sousa of St. Luke's System and Dr. Nemerson of St. Alphonsus. Are Dr. Sousa and Dr. Nemerson both on?
Dr. Sousa's here.
Yes.
Okay, Dr. Sousa, would you please go ahead with your presentation? Bring us up to date, if you would, please.
Will do. Thank you. Over the past 2 weeks, our inpatient activity has been progressively increasing. We set new records for COVID activity across the system, and most of the admissions are now happening in the Treasure Valley. Some specifics on our numbers available publicly. We had 169 COVID admissions across our system today. 23 of those were in intensive care units. 15 to 20% of all of those admissions were in the Magic Valley area, and the remainder are in Boise, Meridian, and Nampa. Our capacity for care has been eroding for weeks, and I guess what I would share is that the margin for error is getting smaller. I'll try to unpack that a bit. Adult hospitalizations have been higher than normal all week. ICU admissions have been higher than normal all week. Today we had 57 intensive care admissions. 40% of those were critically ill adult COVID patients. In Boise, we had both of our telemetry units at greater than 90% capacity, one at 95% capacity. Our 2 intensive care units comprising 34 beds in Boise were at 88% capacity. Our Meridian Med-Surg units are at 90% capacity. One of them is at 100% capacity. Our ICU there is at 86% capacity. And in Nampa, our telemetry unit is at 100% capacity as we speak. And our ICU is at 80% capacity with no boots on the ground, pulmonary and critical care staffing. Speaking of staffing, the real story is staff. We're continuing to experience well over 100 call-offs per day of clinical staff, which for perspective, that's more than twice normal. So we're keeping our neck at the waterline. I want you to know, though, how fast we are treading water to try to keep our neck at the waterline. We are 3 times daily performing standardized aggressive decanting rounds in every acute care facility. That means, right, that case managers, hospitalists, and teams are meeting to try to find the earliest possible moment that a patient can be sent home and move out of our facility to make an open staffed bed. We remain closed to certain elective surgeries, and we're going to be making some further adjustments in that next week. Those adjustments will be to narrow up the number of OR beds so that we can try to free up more nursing staff who can serve in other units. We've aggressively expanded our use of telehealth to facilitate active care management in a transition to the home. So we're scaling up this remote patient management program that we have from 150 patients to 300 patients on that census in order to try to make the discharge day happen a day or 2 earlier. We're employing all HR tactics, incentive pay, PTO banks, what have you, to incentivize our people to work. We opened a new intensive care unit this week. We opened part of our cardiac observation unit as a critical care unit. And with these things, we're kind of creating a lot of churn. And just what I mean by that is, our daily census will swing by 70 or 80 patients from morning to evening as we're aggressively trying to move people out and make more room, because most of the admissions in healthcare, of course, the unplanned admissions happen later in the day, into the evening and into the night. At this point, we are definitely employing what you would call contingency standards of care. Not crisis standards of care, but contingency standards of care. And what that means is we're no longer adhering to our usual modus operandi. We are, for example, restricting, right, access to certain types of care, like certain elective surgeries. We are restricting access to pediatric inpatient care in the Magic Valley. In the past week, we've boarded patients in our emergency department for extended periods of time. That's a commonplace thing in big inner city hospitals. We've never done that. We've never done that. We opened a new intensive care unit. We've extended our nursing ratios with the assistance of telehealth support to be able to allow them to try to manage a bigger population of patients for one nurse. These are all things we've never done before. And on Tuesday night, we were, and I know this is frustrating here, we were this close and we didn't do it. We were this close to going on divert. We never go on divert. We're the state's largest health system. That would be an abject failure. We will move a mountain before we go on divert. And we were that close, and what spared us were some unanticipated deaths. Maybe the last comment is just this margin of error comment that I want to put in here, because it's a real dynamic that we're experiencing right now. Just know that this margin is getting really tight, meaning that a small increase now in community activity, disease activity, leading to admissions, will push us to this limit where we're keeping our neck at the waterline. It'll get us there quickly. I'd also remind folks of something I've said a lot of times in my public comments, that I think we've all learned to respect the speed with which this COVID-19 pandemic can move through a population. I'm really not exaggerating at this point when I say that, if we had a couple of substantial outbreaks in good-sized long-term care facilities in our communities, given the vulnerability of that population and the likelihood of the need for hospital care, like that single event could push us to the limit. And I think the risk of that happening right now has unfortunately increased significantly due to the holiday activity that occurred with, people congregating with others outside their homes, including some of those older folks. So the margin for guesswork is just getting really tight. And the margin for, I think, injecting hope into planning is getting really small. It's a little bit like a train coming down the track. When it's a mile away, you can kind of hope that it's going to stop. And when it's a half a mile away, you can maybe wave your arms and hope somebody sees you and it stops. And when it's 100 feet away, you better start thinking real hard about what you're going to do. And when it's 20 feet away, you have to move. So that's what I'm talking about when I'm talking about the margin for error getting tight. You asked about hospital capacity, so I'll just leave it there and see what questions you all have. And I know Dr. Nemerson has information to share too.
Okay, thank you, Dr. Sousa. The floor is open for questions for Dr. Sousa.
Madam Chair, this is Elt.
Yes, Al, go ahead.
Dr. Sousa, I just want to say I really appreciate all your effort and your energy. You guys are working your butt off, like my old man used to say, but sometimes you got to cut the mustard and sometimes you can slide a little. I guess my question is, back in June or July, we got data that, and please correct me if I'm wrong, but there were somewhere around 560 or 580 beds available in the Triage Valley for this. And some of your data that you got us tonight are 169. I think I remember that number. Am I missing something here? It seems to me like we have quite a bit more room at the hospitals for some of these. Is that a misinterpretation on my part?
So you don't want to count, I mean, we want to count our, adult beds, because fortunately this plague has largely spared children from getting so sick that they need a hospital bed. It's mostly adults who are going to use our hospital capacity. So just internalizing our internal. So this is what I'm about to share, St. Luke's numbers, right? When we move above 400 adult hospitalizations, we move from the green zone to the yellow zone. It's starting to get tight. And when we move above 430, 440, we're in the red zone. That means we're done. We're scrambling for a place to put a person into a staffed bed. We've been in the red zone, I think, 3 times this week, and that's in adult inpatient beds. I mean, you can't count NICU beds. We have a lot of NICU beds, but they're for tiny little human beings, not grown adults who need a big mechanical ventilator and a team of ICU nurses.
Betty Ann, this is Ted Epperly.
Yes, Ted, go ahead.
Yeah, Jim, thanks so much. The report is unbelievably sobering. So thank you for your honesty with this and for both our awareness, but the public's awareness as well, Jim. We all know that the post-Thanksgiving surge hasn't hit yet. That's usually 2 weeks post-Thanksgiving. We know Thanksgiving, 50% of the people traveled across this nation. We know that there were gatherings. We know we're going to have a huge impact. That coupled with influenza typically becoming in its full throttle post-Thanksgiving for the same reason. So in the next 2 to 4 weeks, knowing that right now you're in the red zone 3 of the 5 days this week, your neck is at the waterline. Jim, help us understand as clearly as you can what you're thinking for the next 2 to 4 weeks. That's when the real issues hit.
Yeah, I'm very worried about it. I've gone from on this whole move to crisis standards, which, by the way, I want to clarify something. I've seen things out there that that would be a hospital by hospital. That's not the case. If the governor declares crisis standards, it's going to be a statewide declaration or regional. I mean, it's not going to be a hospital by hospital thing, because, and I want to make this clear, it would be grossly unethical. If I run out of beds at St. Luke's and there's even 1 bed up at Kootenai, I'll get a whirlybird, I'll get a plane, I'll put that person in a car if we have to move them to Kootenai. So that, like, it's, but Ted, I thought crisis standards were nice to have in our back pocket. Then I kind of got a little worried in July, and then things calmed down. And then since October, I've been thinking increasingly, oh my gosh, we might actually use this plan. And I believe it's more probable than not that in the next 2 to 4 weeks, we will find ourselves at that point, unfortunately. And can I make I'd like to make a plea. It feels like it's all I do is beg. a plea that's based on what we've learned in healthcare. And what we've learned in healthcare, if anybody listens to what I just described, you know that if you walked into our facilities, it would feel like a buzzing hive, and it does. And let me tell you that those call-offs, they're happening because of community-acquired disease. It's rare as hen's teeth that we're having a work-acquired COVID-19 infection amongst our employees. So we know how to do it. And I know that it feels difficult to feel like you're being, quote unquote, kind of told what to do. I want to say, I'm not telling anyone what to do. I'm literally pleading, and that's what I've been doing from the beginning. And, most of our stuff that we put out publicly lately, it almost looks like we're begging. Well, I'm not too proud to beg. It saddens me that this has become a debate of good versus bad and right versus left and urban versus rural. And that's just wrong. And it's not political, and I'm not going to lean into that, but I'm going to keep doing my job, which is to keep giving you guys information. And, with Steve on the call here today, I want to call something out that in, the good old days before the pandemic, St. Luke's and St. Al's, we fiercely competed with one another, on who's got the best care and who's got the best experience. And there's no time for that nonsense right now. There is no us and them in the healthcare world anymore. We have banded together against a common enemy. And the common enemy in our community is this virus. Steve and I now talk weekly, sometimes more than weekly, to collaborate on getting us all through this and out of this. And I'd love it if everybody would just please follow that example. There's no right or wrong or Republican or Democrat or urban or rural or religious or non-religious when it comes to COVID-19. There is one enemy, and it's the bug, and there's one victim. It's humanity. So I'm going to keep giving the same message. I'm a physician, and in my role, it's to give people good information. And I also still practice in critical care, and this is a heartfelt statement I'm going to make here. I've had the sad opportunity to take care of patients with COVID-19 in the ICU. And I've had the sad opportunity to take care of any number of patients with any number of ailments in the ICU over my career. It's sort of the last place anybody who's listening tonight would ever want to be. Nobody wants to grow up to land in the ICU. And what you hear there often is, if I had known, or if I had only done X, or, I just didn't realize why. So I'm compelled as a physician, a healthcare leader, like Dr. Emerson, that you're going to keep getting the same message from us to please do the simple things that work. You probably want to ask us about policy decisions to facilitate that. I'm happy to opine on that, but I've already spoken too much, and thanks.
Madam Chair.
Yes, Megan, go ahead.
Thank you. I just wanted a point of clarification and a question with regard to crisis standards of care as set by the governor. We were in a meeting with the governor, saw him today, not a couple hours ago. He indicated that he kind of drew the line at Riggins. So there's actually 2 regions. So it's not the entire state that would be affected. It would be 2 regions. So I got the thumbs up from Jim. So that's my understanding. So apparently that's accurate. And I also asked him if the hospitals had appealed to him for a crisis standard of care. At this point, he said he met with you guys this morning and that hadn't happened. Can you tell me, just walk me through what that timeline would look like if you get to that point, Jim, and how quickly decisions are made or not made, just as far as that functionality.
Yeah, I can try that, Representative Blanksma. So in order to prepare for that, what we've started doing along with St. Alphonsus, and Steve might correct me if I'm wrong here, I think we had our first such meeting yesterday, is we've started to have kind of a regional load leveling type of a conversation where we're meeting regularly as healthcare delivery systems. As it's getting tighter and tighter within each healthcare delivery system, we want to be able to know if it's getting hard to get any air over in this healthcare system and you got 3 beds over there, can we empower our transfer center to facilitate appropriate movement? So, that's another example of the sort of collaboration that, with no direction from anyone, we've taken upon ourselves because we feel like we need to be stewards of this resource to the community. So you're right. We have not asked the governor to implement crisis standards of care because we're churning as fast as we can and still got this little margin above water that I mentioned.
Betty Ann, this is Diana.
Yes, Diana, go ahead.
So I know we have heard this as a board, but we have a lot of perhaps new folks tuning in tonight, and we've received a lot of comments during the week. And I know you guys try to be really measured in the way you talk about it, and that you will still care for people. You just may not be able to treat them the way you would like to. But can you elaborate for what does that mean? I know there's a rubric, and I think this is the really hard thing for us to be able to explain to the public, because so many of the comments that we have received are, they make sense. It's, I take responsibility for my own personal health, leave me alone, etc. However, that doesn't really take into account what happens if somebody gets in a car accident and there's no longer an ICU bed because we're overwhelmed. Can you explain what does that look like? It essentially, from my understanding, looks like you're in a war zone. You're triaging like you're in a war zone. But tell us what you think it will look like for you all.
Yeah. So if crisis standards were implemented, I want to be careful and make it clear that we will always provide care. There's a lot that's wrapped up in caring for our fellow human beings, and it includes, right, shelter and comfort and nutrition and hydration. We're always going to provide care. Crisis standards of care means that, unlike contingency standards, which I mentioned, so in contingency standards, we're doing things differently. And we might be restricting access to certain treatments or certain therapies because we don't have the capacity to do it anymore. We're already in that state. We're not, however, restricting access to care that is necessary to preserve life and limb no matter what. So in the setting of crisis standards of care, those life and limb type interventions, which typically would occur in an intensive care unit setting where you can apply life support, those are allocated based on a scoring system, a severity of an organ failure scoring system that looks at an individual agnostic of any of their demographic features and just looks at them as a biological entity, applies a score, and based upon that score, we allocate or deallocate those critical care resources. So describing it as triage would be an accurate description. The reason for the scoring system is that it's an objective way to try to predict who would derive the greatest amount of benefit from the now rationing of this scarce and sacred resource. Who? And that's how it works.
Okay, thank you, Dr. Sousa. Any further questions for Dr. Sousa? Or any further comments you'd like to make, Dr. Sousa?
No, I'm interested in, haven't checked in with Dr. Nemerson in a couple days, interested in how they're doing.
Okay. Given that, Dr. Nemerson, are you on?
I am. Good evening.
Oh, good evening, and thank you so much for joining us. The floor is yours.
Thank you. Happy to share our data with you, and our situation very much mirrors St. Luke's and other healthcare facilities across the state. Before I go into that, I just want to make an important point, which is not all intensive care unit beds are created equal, nor are all hospital beds, nor are all doctors. It's really important for you to understand that, because the ability to deliver complex medical care, whether it be to a COVID patient who is at the most extreme in their condition, or a non-COVID patient that's at the most extreme in their condition, is dependent upon having a physician who's not only an intensivist, but an intensive care doctor who's used to practicing at the highest level of what we call tertiary or quaternary care, and having a team surrounding that individual that's also able to deliver that care. And the same goes for general hospital beds as well. Having a skilled hospital-based physician surrounded by a team, critically important to deliver the best outcome. And we are beyond the point where we're able to deliver normal standards of medical care, even though we still have some marginal capacity left. And I think Jim's talked about that, but I really want to call it out to explain that just because a bed is available at another medical center, the medical centers that have the highest acuity beds are St. Luke's and St. Alphonsus. And there's St. Luke's and St. Alphonsus in Boise as well. And so under normal circumstances, patient needs an intensive care bed and is getting even worse in their condition, we would ship them over to Boise immediately. Now we're already making bargains within our own systems and across systems to say, well, this patient needs an intensive care bed, is getting sicker. Can we keep them where they're located outside of Boise until such time as they need a therapy that isn't available someplace else? And that's a tragedy, and that's a situation that we're already in. And that situation is going to continue to get worse, and I'll share our numbers in a moment. The other thing you need to realize is our staff are beginning to fall to the side because they've exhausted their endurance. And I'm going to share some of our numbers around those that are on COVID leave or administrative leave, but it doesn't account for those that are having to take extended breaks, and some who've even left the profession of medical practice because this has been going on not for a couple months, but for nearly a year now. And it takes a toll. And I can't even quantify the toll that it's taken on our staff that are still coming into work. I can certainly speak to the toll that it's taken on me. And one of the stories I want to share is now I'm fielding more phone calls and video messages and text messages in the middle of the night, having to negotiate both patients in some of that decision making I've shared with you. Can that patient stay where they are? Do they need to be moved? Can I grant an exception of one sort or another for therapy? And I'm pleased to do that, but so that's a burden that continues to grow. And for our own colleagues, probably the most sacred trust that we have as physician leaders and other leaders of our healthcare system is to keep them whole. And so I am now fielding more and more situations where colleagues have had exposures in the community and need guidance about what to do because there are unusual aspects to their exposure, and can they come into work because they're so committed to delivering the care that is needed and needed now more than ever. So that situation too is going to continue to grow. And candidly, we don't see any end in sight. We expect the growth to continue. Dr. Souza's shared the St. Luke's experience. I really want to emphasize again that whether we reach whatever standards you want to define, contingency standards, more extreme contingency standards, or God forbid, crisis standards, does it really matter if it occurs in a week or if it occurs in a month or if it occurs in 2 months? We still predict that we are going to get there at the present time without any fundamental change in what's going on in our communities. So having called that out in a very sobering way, and I regret that, but I have to be honest with you, let me share our most recent numbers. So 2 months ago, almost exactly, at St. Alphonsus across our 4 acute care hospitals, we had 10 inpatients that were COVID positive or suspected to have COVID. We now have between 70 and 90. And today's number was in the low 70s because we had a significant number of discharges at the end of the weekend, which was fortunate. But we're seeing that steady up and down with a constant trend of growth. And then in terms of our employees who have gotten ill, contracted COVID, again, almost exclusively in the community or in social interaction. At 2 months ago, we had 20 employees in that situation that were on COVID administrative leave. Now we have 140 or so, which is an enormous strain on our medical staff and our ability to deliver care. What I want you to understand is that as the growth in COVID occurs in the community, the growth in COVID among our employees will also increase at an exponential rate. As a result, the number of patients that we'll be able to care for when at the point at which we reach crisis standards of care becomes more, it occurs more quickly. And we can, to Jim's point, we can very rapidly in a period of days go from contingency standards of care to crisis standards of care because of both the overall growth and the inelasticity now of being able to staff beds to take care of patients. And the last number I want to share with you is what we call the test positivity rate. And I know there are many other metrics that we look at as a group and this committee looks at. But that test positivity rate is an indication of the number of people who present almost, in large numbers with COVID-like symptoms and then test positive for COVID. 2 months ago, that test positivity rate in our hands was something like 7%. Now it's about 25 to 30% on any given day. We use that magic number of 5% to describe a pandemic that is under control if it's less than 5%. We say if it's greater than 5%, it's out of control. And I don't know what we call it when it's greater than 25%. I don't know, a forest fire or something. And I'm not telling you anything you don't know. What this means right now is St. Alphonsus is in what we call resource limitation or contingency standards of care, depending upon the definition you use. We've expanded into clinical spaces that we don't traditionally use. And approximately a month ago, I said we were just beginning that process. Now we've got it going on, and we're continuing to harvest clinical spaces that we haven't used before to be able to accommodate our patient volume. We are already using alternate staffing strategies to cover patients. And what this means is at times our nurse to patient ratio change so that one nurse in a given healthcare unit needs to cover more patients than they traditionally would. And we use a team-based approach to nursing, trying to leverage the strength of individual nurses to do certain functions of care delivery. But what that transforms to is the patient's experience is being compromised. So it used to be, in most cases, you pushed your call button and somebody was in your room like lightning. Now, not quite so fast, because that nurse or medical assistant is handling so many other patients. And we're making sure that we're still meeting the needs of our patients, but not the way that we would like to be doing, and certainly not the way that we'll be doing in the very near future. So that's kind of the big picture of the basic experience that we're going through. The last thing I want to comment on is this idea that we've discontinued elective procedures. When we first started this journey of having to consider different care contingencies, and I know I shared this with this group, we talked about the fact that we were prioritizing surgeries into medically necessary categories, and we would certainly do and will continue to do the most critically important emergent surgeries. We are the state's trauma center. Patient comes in with a major trauma, they will get the care that they need. We will continue to take care of the heart attacks, etc. We've not yet reached crisis standards of care where we have to make decisions around withholding that care. However, not all elective or non-medically necessary surgeries are created equal either. A orthopedic surgery is something that we reduce sooner often when it's of an elective nature than we might an open heart surgery, because of the ramifications of how long somebody can continue to survive and do well with those conditions. But here's the thing I want you all to think about and personalize, and I really am not directing it to this group, but I'm directing it to other people who are listening. If you have a cancer, a tumor that is growing in your body, and our hospital says, we're sorry, we can't take that out tomorrow as we would normally have done, we have a line that's been created, and you're number 27 in line, which means we'll do it in 2 weeks. But don't worry too much. We will get to it and we will get it out. Ask yourself, stop during that period of time? Do you think that the spread of that tumor might go beyond stage 1 when it's essentially curable to stage 2 when your chances are kind of like 50-50? Or could it spread to stage 3 when your chances are 1 in 25? And to me, that's what this tragedy is all about, is that's the situation that we're in now. And we may yet get to the point where we say to that individual, well, we can't do the tumor until the surge peaks and begins to decay. And we being leaders of healthcare systems, don't see that right now. So I can't tell you that we'll be able to take that tumor out. Well, right now, I can tell you it's not going to happen tomorrow, but it will happen next week. In a week or two, it might be more like a week to 2 weeks. But if we get to that point, say, I'm really sorry, but we have patients with COVID lying in the hallways in the emergency department, and we're talking about who gets the staff, because that's what crisis standards is going to be about. Who gets the staff to take care of them? So you've just got to keep the tumor inside your body, and we'll do the best we can. That to me is if things don't change. So I'm sorry to present that way, but that's my focus these days. How do I get the people who have those conditions taken care of as quickly as possible so they have the very best possible outcome, understanding that in the near future, I'm going to be more limited in that capacity. And what keeps me up at night is, can I even squeeze through that extra patient to get them that care? Because I know in some period of weeks, I'm probably not going to be able to do that. And that's tough. And then the last thing, again, I want to take us back to where I started, is our people that are delivering this care. If I do that last patient and squeeze them in, I'm taking that nurse and medical assistant and respiratory therapist and physical therapist and nutritionist and pharmacist. And I can go on and on to describe the size of the team that we routinely have to deliver the stellar care that's available in our institutions. And I'm making them work that much harder, and they're already beat. So I'm happy to field questions, and sorry to paint that dramatic picture. But again, I want you really to understand what we truly are facing here.
Madam Chair, this is Diana.
This is Chairman Nettleton. I would like to ask both of you gentlemen to comment on the supply and availability for the necessary medications to treat COVID patients. What is your situation there?
Well, I can go first. So there's a variety, Steve Emerson, Chief Clinical Officer, St. Isles, obviously. So there's a variety of different therapies that are available. Right now, we have an adequate inventory to provide all of them to COVID positive patients that come to us. And I think that's the question that you're asking. There are, first of all, the most important therapies, which are supportive: oxygen, fluids, nutrition, temperature control, these sorts of things. And we're in good stead with that currently. I suppose it could change, but the national looks reasonable, and we believe that that'll be sustainable. Then there's the anti-immunologic types of therapies, dexamethasone and steroids. Again, we seem to feel that that's good. Then there are the innovative therapies that have developed over the past 10 months as we've progressed through this journey. The remdesivir, which the utility of that drug, we thought we were more optimistic earlier, say 3 or 4 months ago. Now we realize that it's probably not as effective as we had quite hoped, yet there's good clinical indication for it. And so at least in our system, and I'll let Jim comment in a minute, the remdesivir inventory appears to be more than adequate to meet what we expect to be demand, perhaps until such time as we would reach higher levels of surge, but that looks good. And then finally, there's the novel therapies of monoclonal antibodies. There's 2 types of those drugs. They're actually drugs if somebody is very early in COVID, so they either have no symptoms or they've just developed symptoms, test positive, and they get referred to our attention rapidly because they have high risk of hospitalization or death if their COVID's allowed to progress. If they meet those criteria, we've got those drugs available, but they're in highly limited quantity. So the demand is not that great for it right now based on the number of patients that are in that window of time and being referred to us. But we expect, based on our predictive modeling, that that demand is going to grow exponentially over the next month to 6 weeks. And within that period of time, depending upon whether the national supply increases, and we don't expect it to be the case.
Okay, thank you so much for your comments. Dr. Sousa, did you have anything to add to that?
Yeah, really well said by Steve. I have very little to add. The only thing I would add is that we're in the same situation in terms of the COVID therapies. But some of the more, broadly applied therapies for critically ill patients, particularly given the amount of respiratory failure we're seeing with this pandemic, sedative drugs like propofol, certain narcotics. I mean, we do have shortages of those, and we're restricting the use of those. We're not at a critical point yet, but yeah.
Okay, thank you,
Madam Chair,
gentlemen.
this is Diana.
Yes, Diana, go ahead.
Thank you. So, gentlemen, I think I know the answer to this question, but again, this is one that's come up a lot in our comments. And as people are asking me questions, I'd like you to just speak to it since we have a lot of people watching. I keep getting questions about, well, we've been in this pandemic for 9 months. How come the hospitals haven't prepared? Or I'm sure that, yes, I'm seeing your laughter, but, or why can't they just hire more nurses? And obviously, you have already explained to us all the things that you've done to prepare, but I guess it'd be helpful for you to elaborate on the nursing component. My understanding is that since we have so many states in the same situation, it's really, really difficult to hire traveling nurses. And in fact, there are some nurses who are going out of their existing job and going out to be traveling nurses because they're making more money. So if you could confirm or deny that, but it would be helpful for, I think, for the public to hear.
I'll confirm. There's not a wellspring of available nurses. Moreover, right, our own nursing staff has been going out sick, acquiring COVID in the community. Every time that happens, they're out, for a significant period of time. And to your point, Commissioner, this is a regional, actually it's now a multi-regional / national problem that we're facing. I was speaking to the CMO at Intermountain in Utah, just trying to understand more clearly their capacity, their availability, and they had converted, I think, 3 or 4 units into intensive care units over the preceding 2 weeks. And when he was citing for me, his ICU capacity, which was around 300, he said, "Oh, wait, it's 330. Yeah, I forgot. We converted that unit." And all of those beds need staff to open. I mean, I'm sure we're all seeking traveler nurses. We think we maybe have some on the horizon in a couple of weeks, but I hope I answered your question. I confirm.
I'll confirm as well. The other thing I want to point out, St. Alphonsus Health System is part of a national ministry, Trinity Health. We have dozens of hospitals across the country, and we have thousands and thousands of nurses working in all of our facilities. And every ministry is asking if there's a free nurse, could that nurse be sent to that ministry? And we're one of those ministries asking for that. And they're not there because we all need them. We also have looked at nurses from other countries to come into this country to be able to serve. And we're trying to develop those possibilities. But remember what I said before about doctors and other staff. They're not all created equal. And so, while it may seem like, couldn't a school nurse or couldn't a nurse that works in a doctor's office or couldn't a nurse that travels around doing blood pressure checks come into the hospital and take care of patients? And imagine how frightening that would be to someone who hasn't been in a hospital since she left nursing school or he left nursing school and has been out in practice doing mobile physical examinations to come into a hospital and take care of even the lowest level of acuity of patient. And we don't want that. But we will do whatever we need to do to make sure that as many patients are taken care of as safely as we possibly can. But that's a limit. And fundamentally, we're at the limits of the staff that we have.
Chair, this is El.
Yes, El, go ahead.
Thanks, you guys, again. I guess the question I have for either one of you is that a lot of the comments we've been receiving, especially this last few days, is the fact that this disease only has about a 1 or a 1.3% death rate or kill rate. And a lot of folks are getting it, getting through it and surviving. A lot of them, like me, went home with the right medication and got over it myself. Is there something else that the medical industry could do to push these people out sooner? That's the question: is how long are these folks in the hospital if they end up showing up? Are they, super elderly? Are they young people? There's just so much unknown data that it seems to me like um, maybe we're trying too hard. Does that make sense? And maybe we need to send more folks home. I don't know. I'm not a doctor, but I have been through it, and I know it's not fun. How do you answer the public on that point?
I would like to say I mean, the mortality numbers you talked about are probably high. And the point is, it's not about mortality, it's about morbidity. Which means, right, suffering. It's about the morbidity, not the mortality, okay? And the point there is that if you get sick enough and you need to use a hospital bed, and we're running out of room in the tank, we're going to need, you've already heard from, I think, both Dr. Nemerson and myself, that we are already applying these contingency standards where the care you get today is actually different than the care you would have gotten last year at this time. Are we all okay with that? Knowing that what we've learned in healthcare is you don't have to be okay with that. With simple practices, we can be crazy busy and still protect our people, our employees, and our physicians and providers. We can keep patients from getting this, and we can keep our lights on. We're proving it every day. Focusing on the morbidity again, what Dr. Nemerson pointed out so eloquently with that example of that patient. I mean, the worst thing that I'm worried about is this pent up wave of disease that we're creating right now because of what we're tolerating in terms of, just allowing the pandemic to continue to spread. If we just do these simple things and get control of it, we can curtail that, and we can start to curtail it now. The last thing I'd say about morbidity is if we keep doing this, and I've been trying to play forward in my mind, trying to answer Commissioner Laciando's question, describe what it looks like in crisis standards. And, I think it looks pretty horrible. I think, as a physician who's dealt with a lot of suffering and dying, I'll be able to handle it. Don't want to. It's totally unnecessary. And I think our staff will fall apart when faced with that. As soon as we see that, though, the amount of mayhem it's going to create, I think I know what will happen. I think we'll get a full-on shutdown of our economy again. And the public health ruination that's going to cause, with depression and anxiety and unemployment and substance use, it's unfathomably bad. And I come back to what I said at the start. We in healthcare have demonstrated none of that needs to happen. So it's about the morbidity, not the mortality. And hopefully the points Dr. Nemerson made landed. you haven't heard, I think, either one of us talk about really death rates, the death counts. They're all bad. What we're worried about, frankly, is the morbidity and the impact on long-term health, because we have an obligation to that.
Madam Chair, this is Jane.
Yes, Jane, go ahead.
I had a couple questions. One is, if in your best estimation, how far do you see that we are from instituting the crisis management care?
I'll take it first if you'd like, Jim. I want to be really careful for two reasons. One is I don't want to panic the public. I don't want to panic any individuals. And I know that this is very, very alarming to hear the information that we're sharing. So that's one thing. And then the other is that, we don't know if perhaps this conversation and others will actually change behavior, and the discussions around mandating face covering and potentially even moving into other conditions where people are allowed to travel less and socialize less, whether that'll actually have an effect. So I hesitate to predict when we would reach crisis standards of care, but I will tell you what our predictive modeling shows. And this is not based on the Thanksgiving effect or what we expect to be the Christmas effect, because fundamentally we can't predict that at this time with a good degree of accuracy. But what we know is based on the current growth rate of COVID in our communities, at least my systems modeling would suggest that we would be in the throes of severe contingency standards in approximately time, so by Christmas, and that we would expect sometime after the first of the year to potentially be in crisis standards of care.
And we're in the same ballpark, only potentially putting those numbers or those situations perhaps a week earlier.
Thank you. And I had one other follow-up question. That is, how does divert relate to crisis management of care?
It doesn't really. The divert concept and what hospitals have had to do is when there's service that's not available. Jim, you may want to comment on St. Luke's was in the circumstance where they were literally about to be out of intensive care beds. Then there's no intensive care bed to put a patient into, and a hospital or health system can make the decision to divert patients away from that hospital that would need that specific service to go to another hospital that still has it available. In terms of the relationship to crisis standards of care, it would be where basically everyone is out of space across the board. And at that point in time, there's no place to divert to. So we would, number one, have to then essentially never divert, because whatever comes to us, there's no place to send those patients. And then secondly, we would have to, circumstance of trying to accommodate patients where there's no more room, we would have to be at the extreme where we felt that we couldn't even deliver what we call standard of care to the next patient to come into the door. And that would be the point at which we would make a plea to the governor to declare crisis standards of care, because we literally would have to turn patients away in some capacity.
Madam Chair, this is Meg.
Thank you.
Megan, go ahead.
Yeah, thanks. I had another quick question, I guess, for either Dr. Souza or Dr. Nemerson, and it's just, we've got a facility, a rental facility, and the company that rents it's called Blue Med. I don't know if you've heard of them or not. They provide mobile facilities for emergencies. So think hurricanes, earthquakes, that kind of stuff. And so I just wondered if in part of your planning, your contingency planning, if you were forced to go to the crisis level, if you had considered that type of additions to the hospitals as far as being able to provide additional care should the worst happen.
Yeah, I'll speak for St. Alphonsus. We certainly have the use of non-clinical facilities and external spaces in our surge plans, but they're more theoretical than they are actually operational because we don't have the manpower to staff them. So in order to open something like that, and the most common thing that you've seen in other areas that have actually had to do this is opening a field hospital. They actually bring in staff from the military, or they repurpose existing staff in one space because they feel they can deliver more efficient care, meaning instead of one nurse in my hospital being able to take care of a maximum of 7 patients, if I put them in a parking garage where I've got 20 beds surrounding them, maybe I can increase the ratio from 1 in 7 to 1 in 10 or something along those lines. So conceptually, those things are doable, but realistically, at least at St. Alphonsus, we've got enough physical space, and we would open conference rooms. That's built into our surge plan. I mean, it's incredible where we will put patients to take care of them. And to your point, God forbid you would have to receive hospital-based care in that circumstance to be cared for in a classroom. But so, yeah, we've got those contingencies built in, but executing on them would be highly problematic.
Agree with Dr. Nemerson, Representative Blanksmith. It's a great, suggestion. And there's been this huge outpouring of, those kinds of ideas to bring us the things we need to provide care. But as I kind of said when I was given my status update, the real story of the day is staff. It's people. We're running out of healthy, well-trained people to be able to provide the care. So we'll go through, like you just heard from St. Alphonsus, we'll go through any number of internal kind of extra spaces if we can get them staffed before we would ever run out of physical space. We both have big buildings.
Madam Chair, this is Ted Epperle.
Oh, go ahead, Ted.
Yeah, again, our thanks, Jim, to you, Steve, to you for your honesty and just making sure we're all on the same wavelength, not only as a board, but as a public. We just need to have people understand the situation. And I would absolutely conclude from this, it's not a matter of if, it's a matter of when. A matter of when we hit a condition in the Treasure Valley in which not only have we progressed from contingency standards, but to crisis standards. As you said, diversion is a different issue altogether. It implies there's a place to go. If there's no places to go, then it's crisis standards. When we look at this as a board, leveraging public health to help with this problem that faces the hospitals, the only tools we have are with masking, with social distancing, and with social gatherings and their sizes. We'll do everything we can from a public health perspective to help with this in a balanced way for our community. It's the only thing we can do. You all have what you can do internal to the hospital. But again, that's kind of after the fact with a lot of issues. So from your perspectives to us as a board and to us as a community, is there anything else that you can see that we can do better as a community now to help not only the hospitals, but the community the best we can. Any other advice or guidance on this that we can help you with?
You know, Ted, I mean, nothing novel comes to mind besides, you know, the things that you mentioned. You know, and I also recognize we're speaking to a health district that sort of bisects a huge population area. And so, you know, one could logically say or ask the question, well, geez, if, I mean, can we really make a difference if, you know, if, for example, Canyon and other outlying counties aren't going to come with us? And my take on that is, I'll take anything we can get. When you're breathing fumes at the top of the tank and it's filling up, it's like, I'll take any extra space we can get. Maybe Dr. Nemerson has a novel approach.
Yeah, but if I had a novel approach, then it would be on the news media and everybody be doing it, right? But no, I want to remind us of something that happened at the beginning of the pandemic. If you remember way back 10 months ago, it seems like a long time ago, but it really hasn't been. When this all started, people were putting signs in their yards saying thank you heroes to the nurse, the doctor, the medical assistant next door. There were all kinds of social media messages about thank you for your service to healthcare workers. They were knitting masks because we were out of N95 and some masks to protect them. People were, in some cases, laundering healthcare providers' clothes because, you know, you could get the COVID virus on you, and God forbid you didn't want to bring it into your home. And granted, we've learned more about how to manage this medically, and so I'm not suggesting a campaign to go start sewing masks again. I hope we don't have to get into that situation. But the words of kindness, the social media messages, the recognizing that my staff are truly heroes, that they're working overtime to take care of patients, the personal understanding of the members of this community that we are now at a point where your ability to get the care that you need, even if you're not going to get COVID and get sick from it and need hospitalization, but you might get in a car accident, or you might have a pneumonia, or you might have an infection of the skin that requires inpatient hospital administration of medication, that's now in jeopardy. Take that to heart. Call up the nurse, the doctor, the medical assistant, the secretary that works in my hospital, and tell them thanks, because that's going to help them to feel good about the work that they're doing. And also stay home, stay away from other people when you can, and wear that mask, because this is a totally preventable disease, and it's dumbfounding that we're in this situation, that we're talking about limiting our ability to deliver care to patients that need us because of something that is essentially completely preventable.
I got to jump in and double down on Steve's comments. Thank you, Steve, for saying that. Our staffs really do need the juice. And it feels like somehow the conversation has changed, and they need to know that their work is valued. They're leaders. like Steve and I, we tell them all the time, but it's demoralizing beyond belief when they're faced with what almost feels like a parallel universe, like you're somehow doing something that's wrong or making up stories about a hoax. I just would remind, we're going to keep pleading for the help, and the people who are making the plea are the same people who took care of your grandmas and grandpas, and they're the same people who took care of your moms and dads. They're the same people who set your kids' broken bones. They're the same people who caught your babies. They're the same people who sat by people you loved and held their hands when they died. These are not, like, none of those people are part of a conspiracy. We're the same people who have been taking care of our communities as long as you can remember.
Betty Ann, this is Ryan.
Yes, Ryan, go ahead.
So I have a little bit of comment and question at the same time, and it's more of a one-sided conversation that is had. But with all the folks out there that are listening to this whole thing, and I mean, I'm 1,100 emails behind. I'm trying to read them all. I'm getting an email. Me and Russ had a conversation about this yesterday. I'm averaging an email every 30 seconds. Even during this call, people begging to not have a mask mandate. And I understand that it's frustrating and it's not fun for anybody. But can you legitimately look your neighbor in the eye and say, I don't care if you get your tumor pulled out tomorrow or if you die from it, because this is a hoax and we shouldn't wear a mask, and you don't deserve care because I don't want to wear a mask. You don't deserve to be taken care of. Because that's literally what you're saying to all these people that are standing in front of you right now on this meeting. When you say that, is you don't believe that anybody else on this planet deserves to be taken care of, but your right to walk around freely, breathing and spitting and doing whatever else on people, because we as human beings have a natural propensity to spread disease. If we didn't, then we wouldn't always have sickness and illness and flu shots and things like that to keep us safe. We are a breeding ground for sickness and illness. And it's, as any medical professional in this room knows, the darkness, damp environments are the greatest place to breed bacteria. And the whole entire inside of your body is nothing but that. So at the end of the day, there's tons of folks reaching out saying they don't want a mask mandate. There's tons of folks reaching out that's unconstitutional and otherwise. But you've just heard these two gentlemen explain exactly what is coming to you. It's not a matter of the death rate. It's not a matter of whether you're going to get it or not, whether you can survive it or not. It's everything else encompassed in the entire circle of the whole entire healthcare system. When there are places in this country, if you look it up, where ambulances are being called to a home because people are calling 911 and they're phone triaging those people over the phone and telling them how to get to the hospital themselves because they won't send an ambulance to go get them for fear that the ambulance workers will become sick. That is happening in America, in other places. That is the reality that you're going to start facing as a public if this continues, and if there is no way to break the cycle. It's going to get worse. It's going to get bad. And a lot of people won't see it, and some people will never even experience it. But some people will go in for a routine issue, or like Dr. Nemerson said, a car crash on 85 on their way home from work and break their leg at the hip or whatever, and they end up needing a minor surgery and they're going to get sent home with some pain meds and some rationing of care until there's time to take care of that injury that's not going to kill you, but it's probably going to deform you for life, and you'll probably never walk right again because you didn't want to wear a mask. And that really hurts my feelings as a human being, as a person, because yeah, we all have rights, but those rights, they go both ways. And I just feel that at the end of the day, everyone deserves to be taken care of. Everyone deserves the same level of treatment. And even though I'm not for taking anything from anybody, ever, and that's not ever my plan or life, but you're literally telling yourself you're okay with risking and rolling the dice on your own life over something super simple like a bowel obstruction just because you don't want to wear a mask or stay away from people or whatever the case may be. Whatever the best result is for stopping the spread of this illness, it's not the illness itself that's going to end everything. It's not the illness itself that's going to kill off everybody. It's other things are going to lead to, there's nobody to take care of you. You heard these two gentlemen. There's nobody to take care of you coming up in the near future. No one to take care of you. No one to help you. You're going to have a simple sickness, and you're going to have to do what they did in the 1900s and sit home and hope you can survive it yourself. And it's sad that we have gotten to that point over a piece of cloth or fabric because people take it that offensively. I appreciate you guys greatly. My mom works in healthcare. I work in healthcare. My wife works in healthcare, and I appreciate both of these gentlemen greatly. They have an incredibly ridiculous responsibility right now, and I would hate to be in either one of your shoes, gentlemen. I'm sorry you're where you're at, but you know, I do appreciate that you are there because I think you guys are doing a great job. And you know, if anybody wants to add on to that, then please feel free. That's all I have.
Thank you, Ryan. Well, this is Betty Ann, and I will add on that too. I have spent a career in healthcare also, and Dr. Nimerson and Dr. Sousa talk about showing appreciation to their staff. I would very much like to show appreciation to you gentlemen, on behalf of our board. So thank you. Further questions for Dr. Sousa or Nimerson? Discussion points? Well, hearing none, I once again thank you for your enlightening discussions tonight, and hopefully the public that is listening in also appreciates the message that you have given and taken it seriously to heart. So thank you once again, and we look forward to hearing you from you in the future, hopefully with better news. So thank you.
We certainly hope so as well.
Yes, go ahead. I'm sorry, I didn't hear that.
Dr. Nemerson said we certainly hope so, and I echo that. And thanks for the opportunity, and thanks for your leadership.
Okay, thank you so much, and good evening to you, gentlemen. Russ, are you on?
I am, Betty Ann. Thank you. I am.
Okay, proceeding forward with our agenda tonight, we come to discussion and vote regarding potential actions to protect life, health, and safety within the district as to the COVID-19 pandemic, to include a district-wide public health order. And I believe you have some comments that you forwarded to
Yeah, sure. Thank you, Madam Chair. So we, as was noted, we did receive a lot of comments through email. We received a lot of comments through our call center. We received a lot of comments through the process that we put forward, which is to use that voh@cdh.io.gov email address. And from those comments, I have, obviously reviewed them and talked with my team here about what the orders could look like if we were to modify them compared to the ones that we posted for the public to view and for you to consider tonight. So my recommendation is, rather than vote on the orders as they were drafted, and again, the intention of that was for you to review it, you as the board, and for the public to review it, provide comment, and then for us to take that under consideration. I think there are some changes that are warranted, and my recommendation is to allow us some time to get that back out to the public, which we should be able to do by tomorrow morning through our website, and then take the time, provide opportunity for the public to weigh in again, and then take this up next Tuesday, which is one of the regularly scheduled Tuesday meetings at 5:15. And again, I guess I would just say I can't emphasize enough how important it is for us to take the steps that need to be taken. You heard from the health systems. What you haven't heard from are the primary care providers out there who are having to close clinics. They can't keep up with the patient volume right now, so that's something we may want to invite a primary care provider to our meeting next week. And as Commissioner Sturm talked about, working in the EMS emergency response, having a difficult time keeping up in that field as well. And I know that is a challenge here in Ada County also. We only really have some basic tools to slow this down. We don't have a vaccine yet. It is, I think, right around the corner, but it's going to be several more months before it's readily available to the public. And we have entered the most challenging time of year as far as trying to stay distanced from others. It is the time of year where we usually get together and celebrate our families around the holiday season. And I'm very concerned about where this is going to go, not just considering what the health system medical leaders have just shared with us, but with what our data is showing. The case counts continue to go up. We break records almost on a daily basis. And the information we have about the health systems as far as hospitalizations, and we're looking at district-wide, not just system by system, again, continues to break records. So I would request that the board allow me the opportunity to make some revisions to the orders, get them published, take public comment, and take this up next Tuesday at 5:15.
Madam Chair, this is Diana.
Yes, Diana, go ahead.
Thank you. So Russ, a couple thoughts. One, I appreciate that, you like us are looking through all the comments. I want to make something clear, though, that it's not the quantity of comments received or even the intensity of some comments. It's about getting new information and actionable information that can help us make better decisions. So I think that's number one. But the second moment I want to take here is, well, I agree with Dr. Souza that we need to do what we can. I'm going to use this moment to just make a statement that we are beyond the point of this being a local control issue. And I would like the board to entertain the thought of sending a letter or something to the governor asking for more of a statewide metrics-based approach. As I am looking at our cases per 100,000, none of them in our district are anything to write home about. Boise County is 40 per 100,000, Valley 51, Elmore 41, Ada County, we're 79. But right next door, Canyon County is 95 per 100,000, Owyhee County 108, Gem County 138 per 100,000. And all of those people are coming to Boise because you just heard it. They do not have the ability to take care of them in their communities, and many of those places do not have hospitals. So I think we're beyond the point of being able to really think about this in any sort of logical way, health district by health district. And I think we need to ask the governor to be taking more of a leadership role at this point.
I second that.
Chair, this is El.
Yes, Al, go ahead.
You know, Dan, I kind of agree with you a little bit. I'm really excited to know that at least they're meeting. It seems like maybe weekly. I mean, they both doctors said the day that they met with the governor, they are in discussion. I'm sure the governor's probably on this pretty hard. But it's a tough deal because a lot of folks have felt like, you know, because of the death rate is so small, what is the big issue? I keep getting that comment over and over and over. And of course, the other one is, you know, why my kid can't play sports, why you guys stopped all these outdoor activities. And I would, if it's all right with Russ, I would like him to kind of explain to the public that's on now that we set up the guidelines, but it's the schools that determine all those sports activities and after school activities. And you know, to be honest with you right now, the way that it's written tonight, I have a really hard time supporting any kind of a deal where we're going to start issuing citations. I think that's going to create an opposite effect in people and drive a wedge between a lot of folks in Idaho, and I just don't think that's the way to go. So kind of a whole bunch of stuff there once, Russ, I know, but I hope you keep that in mind when we're redrafting some of this down the road. I hate to see cops out giving folks tickets for not wearing a mask.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yeah, I know that came up at the last meeting, the question of enforcement, and it is up to our local law enforcement agencies to determine what level of enforcement they provide. I do know it's been very public that the city of Boise has stepped up their level of enforcement, and I know for certain their first line of defense was education. They took the time to educate the businesses and to educate the communities, and people are not going to get cited for making a mistake or making an error. The people that they're working with right now in terms of citations are blatant disregard and putting others at risk. I had a conversation with the city of Meridian. They are also doing the same thing, and they will issue citations for people who are putting others at risk. That would be somebody who goes into a business, for example, or multiple people without a face covering on. And essentially what they're doing is they're just harassing businesses and making other customers feel very uncomfortable. And quite frankly, they're putting them at risk. So they're taking action as well as in Meridian. I know many of our other cities, the mayors are reaching out to businesses who they're getting complaints about. The city of McCall, I know they're taking this very seriously as well and really have since the start. And the list goes on. So, you know, it's not Central District Health issuing citations. It's up to local law enforcement. It's up to local elected officials to decide how serious they want to take this in the community. It's our job to provide the guidance, and in this case, orders to ensure compliance with the things we need them to be doing. And for most businesses, when I look through the orders, for most businesses and most people, it shouldn't be a big deal. Those things should already be being done if, in fact, you want to help our communities avoid what the two medical leaders shared with us tonight. And as has been said time and time again, you know, we are in the business of prevention, and Central District Health right now and the communication we provide to the public and how the public responds to that will make or break where we end up here in 3 to 4 weeks from now.
Okay, thank you, Russ.
Madam Chair.
Any other comments?
Thank you, Russ.
Yes, Madam Chair, this is Ted.
Yes, Ted, go ahead.
Yeah, I'd like to say a couple things. First of all, I agree. Let's slow down our process. Let's try to get this as right as we can with the order for the public. Agree with not taking an action tonight, Russ, as you've outlined. Agree with modifying this, getting it back to the public to take a look at Saturday. We'll take it up on Tuesday to get as right as we can. I just want the public to understand that we have a hurricane coming. All the warning symptoms and signs are there. We just heard tonight that the hospitals are at the water point of just having their head barely above water. It does not take and will not take much to tip them over. Several of the hospitals in the area have been at times on diversion. They all have staffing challenges. They've modified elective surgical procedures. They're deferring standards of medical care that are happening. They're trying to free up beds, sending patients home early with telehealth and telemetry. They are realigning other units. These are the warning signs. These are the warning signs of the impending storm that will happen. As I mentioned a little bit earlier, this has gone well past if it's going to happen. It's when it's going to happen. And I just remind the community that the timeline on this that we heard is roughly at the Christmas or a week before Christmas timeline. So it gets to something that I want to now say, and I appreciate Commissioner Sturm speaking up. We all need to take accountability for this. It's within our control to do this. It's our ability to wear a mask, to pay attention to social distancing, to limit social gathering size the best we can. That is our obligation to this situation. And I would just implore the community to please do your part. We'll do our part. The hospitals will do their part. Please do your part. If we all take accountability for our own actions, because we can't control those of others, we'll do the best we possibly can with this. And Betty Ann, with that, I'll stop.
Okay, thank you.
Madam Chair?
Okay, yes,
It's
Megan,
Megan.
go ahead.
Yeah, if I could make just a couple of comments, please. I'm glad that the order is going to be reviewed. In its current form, I am definitely not in support of it in any way, shape, or form. I have some pretty serious concerns about the penalties associated with orders that come from the public health district, because we're talking about pretty severe penalties when we're talking misdemeanors. I was frustrated earlier this week when whoever runs the Central District Health webpage decided to post that we were not going to read emails. I would like to encourage the public to send your emails. That was a completely inaccurate statement. It made me very angry that someone on staff got to make a decision for me on what I was to read and how I was to consume those emails. I think it's important that we get public input, because if you want to implement these changes, doesn't matter what it is, you need to have the consent of the governed. And right now, sitting in this building, I can tell you there are quite a few people outside that are not interested in this particular order. So I think it's important that we do take the time to get additional public input. This was my concern on Tuesday for going to a meeting on Friday to try to push this type of an order so quickly. So I guess thank you, Russ, for reconsidering. Thank you for reviewing it, and thank you for listening to the comment. I do appreciate that, and I think it's very important, particularly the magnitude of what could be attempted here. Thank you.
Madam Chair, this is Diana.
I just got some feedback then on the line. I couldn't understand what was being said. Somebody trying to speak?
Yes, Madam Chair, this is Diana.
I'm not understanding that.
Madam Chair, this is Russ. Commissioner LaCianda is trying to speak, but for some reason there's some interference with her sound.
Okay. Russ, I don't hear anybody else speaking up at this time about, any further discussion on...
Betty Ann, this is Ted again. I'd like to say something else.
Yes.
Thank you. Just picking up on the point of accountability, We don't, and I agree, I do not want to see us getting to an enforcement issue as well. We shouldn't use our police nor need to in this fashion. And that's my point on accountability. If we all take the personal responsibility and accountability, we won't need to enforce anything. We'll all just naturally take care of each other by doing so. So please, community, understand that. Let's not go to enforcement. Let's just be personally responsible. If we do, then we can help. I do want to call out one group of heroes that go unnoticed in a crisis like this. And their role may become more and more important in the community. And I know I heard from several of them in the last couple days. And those are nurses that are working in the community health sector and the hospice nurses. What happens when hospitals fill up and when they discharge people home earlier is that the shift of healthcare shifts into the community and into the home. And they are doing an unbelievable job in stepping up to help with community nursing in the home setting and in the hospice setting for those less fortunate. And our thanks need to go out to all of you for what you're doing and what you're going to continue to do as we try to get through this the best we can over the next couple months. So I want to call out the community health nurses and the hospice workers for everything they're doing. Thank you all.
Okay, thank you. Russ, at this point, we do not need a motion for to table this and have the staff and you work on it some more. The advisory in our county that we put out, I have, as I stated previously, I have been pleased to see the response to that. However, I get zero support from the emails and everything. There is no support in our county for a mandate. So that's, I have spoken to all of the elected officials in the county as recently as last evening, and they were in unanimous opposition to a mandate. So I have been pleased at the advisory and people's willingness to step up and do the right thing. So,
Madam Chair.
we just, sort of.
Can anyone else hear me?
Yes, better.
Okay. Okay, thank you. So I wanted to pick up with what I said before. And to your point, Betty Ann, when I'm looking at Elmore County's case rate of 41 per 100,000, which again is not great, but is, you know, about a quarter of what Gem County's case rate of 138 per 100,000 is. And both of these counties are going to be feeding into our county when, you know, things get bad. They're going to be coming to Boise. So even though we cross different health districts, I am wondering if there's support out there. I did hear a second from Ryan to draft up a letter, and I can, you know, certainly take a first stab or ask the staff to do so, to ask for the governor to pull together, if not a statewide, a more regional approach based on metrics. Some of the challenges that we are having in Ada County have to do with the fact that you can cross right over the border and it's a different set of rules. And it's very confusing and frustrating, and then people lose trust. So I can make that into a formal motion, but would appreciate hearing what the board has to say about that before I do.
I'd like, if Megan would weigh in on that. I think maybe she has some of the most recent information regarding that. Megan, do you have a comment?
Yeah, thank you, Madam Chair. I actually was hitting my unmute as you were asking. So first of all, if you choose to send a letter, I would like it to be signed by individual board members because I do not want to be on the letter. Second of all, the governor is getting continual updates. Like I said, when I talked to him today, we had a leadership meeting. I was in the room with the governor. He's getting updates They're making decisions based upon the metrics that he has set himself. So they have a plan on the state level. I think perhaps that sending a letter is not an effective tool. It's a letter. And I also think that for the board to essentially reprimand the governor, I don't know that that's for not doing enough. I don't think that's a wise.
With all due respect, I'm not talking about a reprimand. He has put this on our shoulders from a local level. What I'm noting that is that this is no longer effective on a health district by health district level. This is a regional issue at this point. And it's new information to me tonight, so thank you for sharing that if we move to crisis standards of care, the border will be Riggins. But that means we will have people feeding into Ada County from the whole southern half of Idaho. So as a health district, while we can only affect what we can affect, it's time for us to tell him, if others agree, that we're no longer able to be effective in this role the way this is currently playing out.
Madam Chairwoman, did you want me to finish?
Yes, and I would appreciate if someone needs to speak, if they would be recognized and not interrupt. Go ahead, Megan.
Thank you. I think that the tools we have are the tools we have. I think that the governor is using the tools that he has to the best of the ability, whether we agree with him or not. He's making his best effort, and he does have a set of standards that he's reviewing, and he does have data that he's reviewing, and he is meeting with the healthcare professionals that are in our local area as well as throughout the state. Whether you agree with what decisions he's making or not, that is not a comment that I'm wading into. But what I'm saying is that to say that he doesn't have a system or a set of data, that's not necessarily, I would argue that's inaccurate. So to send a letter that says that he needs to develop one, there is one that exists, one just might not agree with what he's doing. So I guess that's my comment on the letter on why I do not wish to be on that letter, I guess, quite honestly.
Okay, thank you. Russ, I'm going to defer to you again, and we're kind of running long here, and if you want to just table this discussion until next week after staff works on this issue, and we will take it up then. Correct?
Yes, Madam Chair, that's my preference. Is I'm going to have the orders revised, and we'll get them posted, and then hope we'll get good feedback from the public. And again, I think Commissioner Lasciando pointed out it's not a matter of the most comments for not wearing a mask being the change that we make. We're going to be very thoughtful about it and try to evaluate the benefits versus the negative aspects about it. And I would just put that out there, just like with school sports, definitely high risk, but there's a lot of consequences too, to not allowing student athletes to participate in sports. Again, that's just an example of something that we're seriously evaluating, and the orders will be published no later than tomorrow.
Okay, thank you, Russ. Russ, as chair, in view of the situations that are, rapidly developing, would the board like to share that, or just set aside the new amended agenda item to talk about meeting schedules next week? Russ, how do you feel about that?
Yes, Betty.
Are we on a tight timeline?
This isn't a comment, this is a question, and I'd like to ask a question of the board.
I don't know what's...
Betty Ann, we have a person in the room who is talking, and what so I can't really exactly hear what you said. I think we can wait until next Tuesday to address the issue of the schedule for the remainder of the year.
Okay, I appreciate that, and I think we'll just share that agenda item until next week. And at this time, I would call for a motion for adjournment.
Madam Chair, this is Eld. I'll make that motion.
Okay, thank you, Eld. Do I have a second?
Yes, this is Jane.
Okay, thank you, Jane. Any further discussion before I call for a vote? Hearing none. Elmore County?
Representative Blanksma votes aye.
Okay, thank you, Megan. Ada County, Dr. Young?
Jane Young, aye.
Ted Epperly, aye.
Commissioner Lachiondo, aye.
Boise County, Commissioner Sturm?
Commissioner Sturm, aye.
Commissioner from Valley County?
It's all what's his name, and I say aye too.
Thank you, El. Okay. Motion to adjourn has passed. Our next meeting is scheduled to be next Tuesday, December 8th at 5:15. So thank you for the public that is listening in and for your participation and emails. They are being taken into account. So thank you and good evening.
Stay well, everyone.